My name is Jeff Barnes. I'm from the University of Michigan, and along with my co-moderator, Dr. Philip Haddad, we're really excited for this session. We're going to jump right into it because we have a number of talks covering really a breadth of anticoagulation issues. So I'd like to invite to the stage first Dr. Brett Carroll. He's going to talk to us about Provoked VTE. Should we be using short courses or indefinite anticoagulation?
Thanks, Jeff. Good afternoon, everyone. I appreciate the opportunity to speak to you about a topic that I think has been a moving target over the last year with new data. So I don't have any disclosures. So we all know that there's a high rate of recurrent VTE after an initial event, particularly those that have had an unprovoked event, ranging from 30 to 50% over 10 years. But notably, there's a significant increased risk of recurrence in those that have had a provoked event as well, over 10% in the first 2 years and upwards of 20% after 10 years. But it's important to appreciate that not all provoking events are equivalent. There are weak provoking factors such as travel, estrogen use, lower limb trauma with only transient impaired mobility. And then you have strong provoking factors including major surgery, trauma, acute medical illness with prolonged immobility. Any of those chronic conditions in the middle that are persistent inflammatory states such as obesity, IBD, COPD, and heart failure. And it's important to incorporate these when thinking about an individual patient's risk of recurrence. Those with a strong initial provoking risk factor have relatively low risk of recurrence, while those with a weak initial provoking factor have a higher rate of recurrence. This is likely because there may be an underlying unrecognized predisposition to thrombosis in this patient population, thus increasing their risk for recurrence. Similarly, those with a persistent initial risk factor are increased risk for recurrence, while those with a transient time-limited defined risk factor are at a lower risk of recurrence. This is a systematic analysis looking at patients that had an unprovoked event versus a provoked event that was non-surgical and those that had a provoked event that was surgical. You can see the rate of recurrence was much higher in those that had provoked non-surgical event compared to a provoked surgical event. And not surprisingly, those with an unprovoked event had the highest rate of recurrence. Similarly, in a study out of Australia, they evaluated the risk of recurrence based on the initial provoking factor as strong, intermediate, or weak, and found that those with an initial strong risk factor had a relatively low rate of recurrence compared to the other groups. So how do we take this data and extrapolate it to a patient we're seeing in the clinic that had a previously provoked VTE in determining the ultimate duration of anticoagulation? This was a nice pooled analysis that combined the Einstein Extend trial, which was rivaroxaban 20 milligrams compared to placebo after an initial 6 to 12 months of anticoagulation, and also combined it with the Einstein Choice trial, which was published in the last year, comparing rivaroxaban 20 milligrams, rivaroxaban 10 milligrams versus aspirin, again after initial 6 to 12 months of anticoagulation. This study then divided it out by what was their initial provoking factor. Was it an unprovoked event, a weak persistent, weak transient, or a strong transient provoked event? And again, not surprisingly, those in the unprovoked event had a high rate of recurrence of about 8% in the first year. That was significantly decreased by rivaroxaban, and also, but not to the same degree, by aspirin. What was interesting is if you looked at those with a weak persistent or a weak transient event that was considered provoked, they also had a relatively high rate of recurrence of about 7% after that first year. Also, they had a significant decreased risk with rivaroxaban. Again, aspirin also decreased the risk, but to a less degree. Also interesting in this grouping is that if you look at those that had a strong transient risk factor, there's no bars there because none of them had a recurrent event. Although a relatively small group compared to the others, I think this signals that those with an initial strong transient event are at very low risk for recurrence. What's also notable about these studies is there was no risk difference in major bleeding compared to rivaroxaban versus placebo or rivaroxaban versus aspirin in the individual trials. So putting it together in the last minute here, I think it's important when you're seeing a patient with a provoked event is to note that all of them do have an increased risk of, can I go backwards? All have an increased risk of recurrence, but there's a spectrum of provoking factors when looking at an individual patient. And you must risk stratify that patient as what is their independent risk of recurrence in the setting of a provoked event. And it's important to note that those with chronic comorbidities such as COPD, CHF, CKD are also important in determining risk of recurrence. I think we now have evidence to support the use of extended duration anticoagulation in those patients with a weak transient or weak persistent risk factor, while those with an initial transient strong risk factor likely have a lower rate of recurrence and are probably more appropriate for a time-limited defined course of anticoagulation. Thank you.